Yeah. Now question and answers. Okay. Can you read out, Naresh? You want me to? Yeah.
Definitely, sir. I will read out.
Yeah. You. If you can read out, it's good. Or else I want. Yeah.
Sir,
Yeah. This is my good friend Dr. Humayun Hussain, who works in the Saudi Arabia actually, in the Department of Internal Medicine. Usually, the question is usually we start sitagliptin in type 2 diabetes patients when we want to use DPP4 inhibitors, gliptins in normal renal and liver functions. Can we use linagliptin instead of sitagliptin in such patients? Yeah, can you read out the question? I'm not able to see. Yeah, can you? Whereas then why gliptins are? 1 second. Seems it's a very lengthy question. Usually we start sitagliptin in type 2 diabetes patients. Yes, okay, because that was the first one available. Okay, when we want to use DPP4 inhibitors in normal renal and liver functions, can we? Yeah, okay. Can we use linagliptin instead of sitagliptin in such T2DM patients? You can always use whenever the normal kidney function is there, normal liver function is there. There is no absolute difference actually. You can use either sitagliptin or linagliptin. That's not a problem. And can we use linagliptin instead of sitagliptin in such patients, T2DM patients with normal renal and yeah, anything is good as far as your renal function and hepatic function is concerned, Dr. Umayan Hussain, first of all. And the gliptins, the DP4 inhibitors prevent the breakdown and therefore enhance the concentration of endogenous GLP and GIP. Then why gliptins are weight neutral? Whereas the GLP-1 receptors are so effective, whereas GLP-1 receptors actually, okay, yeah, they see even the GLP-1 receptors and the SGLT2 receptors are very effective in weight reduction, and they are weight neutral. As you see, per se, I never said the gliptins they reduce the weight. They are almost weight neutral, and sometimes we find a marginal weight reduction. They put on weight with this particular thing, and the question is very lengthy. Whereas so effective. Also, similarly, why the so difference in cardiovascular benefit between the DP4 inhibitors and the GLP-1 receptor agonists? See, the mechanism is so though they are all called the incretin therapies, the mechanism of action of DPP4 inhibition is totally different, whereas the GLP-1 receptor agonist is totally different. Humayun Hussain. See, that is the reason why we have this particular the cardiovascular the protection is seen only with the GLP-1 receptor agonist because basically it reduces the weight very significantly. The reason is very simple with the GLP-1 receptors. Why the reduction is so high is this produces the nausea, vomiting in almost 80% of the patients who are on this, either the liraglutide or the semaglutide or the even the latest tirzepatide also has come. See, all the patients, they have some amount of nausea, vomiting, diarrhea with this particular GLP-1 receptors. They take only very less quantity of food. That is the reason why you see the greater reductions in the weight with the GLP-1 receptors when compared to any other class of drugs. Like the second thing is there is a lot of difference in the dosage, the adjustments, where when liraglutide is used as an anti-hyperglycemic agent, it is in very low dose, whereas the same thing once a week liraglutide, where they used with a different brand name. The Victoza is the brand name given for this the diabetes population. for liraglutide, and the Saxenda is the one that is given for this particular liraglutide. It is given at the high doses, 1.8 milligram, starts with 1.2, 1.8 and 3 straight away. Whereas even the same molecule semaglutide also, the oral pill is there already, that is called the Rybelsus, which is available in the 3 milligram, 7 milligram and 14 milligram. But all the trials were done with only the 14 milligram, not 3 milligram or 7 milligram. And they exerted a significant weight loss, the mechanism being the same. And even the injectable semaglutide for anti-hyperglycemic agent, it is called this particular Ozempic, and the one which is used for the weight reduction is called the Wegovy actually. So which is not available in India per se. Till today, you don't find the semaglutide injectable one in India. Maybe you are getting in Saudi, but we don't have any clinical experience as far as we are concerned as Indian clinicians. So, next question is again from Humayun Hussain. Any clinical benefit effect on linagliptin on NAFLD and MAFLD? Okay, yes. Yeah, NAFLD is the term actually used all these decades, and now it has become the MAFLD actually. The International Society for the Hepatology has changed the terminology. It doesn't mean that other things are changed, they remain same. There is no additional clinical benefit actually, but it doesn't worsen the hepatic impairment as the hepatobiliary disease is concerned. So there is no regression per se as far as linagliptin or any other gliptin is concerned. But linagliptin can be used safely in patients with type 2 diabetes with no liver disease and with liver disease. That is the difference. See, all other drugs except vildagliptin, say Lina and the Vilda, the Sita are the drugs which can be used safely in the presence of or absence of hepatic the disease, the hepatobiliary disease. But there is no favorable effect. But the NAFLD and MAFLD treatment is a multi-pronged approach. See, the first, the main pillar is the diet, exercise, and reduction of weight. These are the main pillars of the treatment. The cornerstone of the treatment is nothing but lifestyle modification and therapeutic lifestyle changes. That is, the 5 components must be incorporated very strictly as far as you are treating a case of the NAFLD or MAFLD or the NASH or MASH or the chronic liver disease is diet, exercise, reduction in the weight, cessation of smoking if applicable, cessation of alcohol if applicable, first of all, and followed by a wide variety of drugs, which starts from earlier we used to think that metformin is the first drug of choice for MAFLD or NAFLD. Now it is changed. The international consensus has come to a common consensus that the pioglitazone is the drug of choice, the insulin sensitizer, the thiazolidine is the drug of choice for NAFLD or MAFLD. That too to be used in the maximal dose, that is a minimum of 30 milligram a day to 45 milligram a day. So 7.5 where we use in our clinical settings the patients suffering from type 2 diabetes to minimize the complications of this particular thiazolidine, we start with a low dose 7.5 or maximum 15. But whereas a case of NAFLD or MAFLD is concerned, and MASH or NASH is concerned, or chronic liver disease is concerned, you have to start the pioglitazone with the highest dose to have the maximum benefits. See, some studies have shown that the large dose, that is 45 milligram of pioglitazone, has shown to reduce even the scarring, the fibrosis process also. Nothing can reverse the fibrosis. The scarring process is nothing but cirrhosis. So even there also you have a role of this particular pioglitazone, followed by metformin, and followed by the vitamin E in the dose of 400 milligram twice a day, and the statins and the fibrates and the DPP4 inhibitors, and the SGLT2 inhibitors, and the GLP1 receptor agonists, and the saroglitazar, the only Indian molecule that is used to treat either the familial hypertriglyceridemia or the abnormal triglycerides when it shoots up to 1400 milligrams per deciliter. We use along with the fibrate, we use statin, fibrate, and the saroglitazar 4 milligram is available. That is from the research molecule of Zydus actually. So these are all the drugs to be used to counter the MAFLD or NAFLD. So alone linagliptin cannot do anything actually, but the point I highlighted is there are certain safe drugs to be used in the presence of liver disease, and certain drugs are not to be used. The safest one is linagliptin, either in the clinical setting of chronic kidney disease or diabetic kidney disease, or the clinical setting of the hepatobiliary diseases. Linagliptin can be used very safely without any dose adjustments and dose titrations. That's what I said, Dr. Humayun. And one more question by Dr. Humayun Hussain. Any clinical beneficial effect of no, sir, sorry. Can we use the DPP4 inhibitors, linagliptin, in pre-diabetes, that is IFG and IGT? It's a wonderful question actually. So, see, pre-diabetes is a clinical condition wherein you need to be very, very cautious. You need to pick it up at the stage of pre-diabetes, either IFG, impaired fasting glucose, that is a blood glucose of 100 milligram per deciliter to 125 milligram of deciliter, and IGT. IGT is impaired glucose tolerance. You can never say IGT, you can never diagnose IGT without doing a 75 gram oral glucose tolerance test. Only after doing the oral glucose tolerance test with 75 grams of anhydrous glucose as per the recommendations of the World Health Organization, if the second hour value is around 140 to 199 milligrams per deciliter, you can label it as IGT. See, the pre-diabetes is either IFG or IGT, or put together IFG and IGT. That makes a complete sense of the complete definition of pre-diabetes. See, pre-diabetes is very, very important. So I tell you, the first point is, if you cannot diagnose, if you cannot screen the patient at the stage of pre-diabetes, he is definitely going to be an over diabetes in the near future. That is, at least a period of 3 years is sufficient where pre-diabetes can become a diabetic. So reversal is a debatable issue. I don't want to debate with you as far as the reversal and the cure and all. There is no cure for type 2 diabetes, but okay, some say there is the reversal even accepted by the American Diabetes Association, accepted by the American College of Endocrinology, accepted by the American Association for the Clinical Endocrinologists, but that is never guaranteed. The time period of reversal is never guaranteed by any international organization so far. So they are able to do it with the diet and exercise, with intermittent fasting. Of late, only 3 days ago, the study, a large study rolled out, saying that those who are on the intermittent fasting for a period of 10 hours or more are at more increased risk of the 91% cardiovascular disease and death. This is a point to be taken. Everybody should should keep it in mind that intermittent fasting is going to kill the patient miserably. Now it has become a fashionable thing for everybody. everybody nutritionist, everybody damn carry says intermittent fasting, intermittent fasting. Eat only when you are hungry, don't eat when you are not hungry. So you get into hypoglycemia, you miserably die. The incidence is 91% increase in the cardiovascular disease and the mortality and the morbidity, which is to a high tune, it is not at all acceptable. So please don't go for this reversal, intermittent fasting, magic shows and all. It is high time to put a full stop all these trials and all. And first thing is to prevent pre-diabetes to become diabetes is to pick up the patient at the level at the stage of pre-diabetes, give counseling, diet, exercise, weight reduction, and all the therapeutic lifestyle changes. What I said: stop alcohol, stop smoking, and start metformin. This is the recommendations by American Diabetes Association. The minimum dose is 500 milligrams sustained release metformin, and the maximum dose for a pre-diabetes you can use is like diabetes. It is 2 grams a day. That is 1000 milligrams in the morning, 1000 milligrams in the night. The only drug of choice apart from the non-pharmacological therapy is only metformin. No other drug can be used. And the second significant point why we should focus more on pre-diabetes is like two clinical settings. The incidence of cardiovascular disease, incidence of cardiovascular morbidity and mortality is one and same in pre-diabetes and type 2 diabetes. So that is the take home message. And third point is as far as the kidney disease is concerned, the incidence is same in the pre-diabetes and the diabetes. So you want to prevent the miserable preventable deaths. So as there are some the modifiable risk factors and unmodifiable risk factors. Likewise, you have the preventable deaths and non-preventable deaths. So at least we try to prevent the preventable deaths. Like cardiovascular disease is always one. The chronic kidney disease or the diabetic kidney disease is one preventable complication. You can prevent the death because of heart, death because of kidney. And most of the times, the surprising aspect is the patients suffering from chronic kidney disease or the diabetic kidney disease, they don't die of kidney disease, rather they die of cardiovascular disease. That is the reason the 2 points you have to bear it in mind always is, one is the earlier so-called the microalbuminuria, now replaced is the urinary albumin creatinine ratio, is the sensitive indicator for the future cardiovascular disease. So you get this case in the near future, in the next 10-20 years, the patient is going to get cardiovascular disease and die miserably because of cardiovascular death. And second thing is this erectile dysfunction. Erectile dysfunction, I say it is attack on the penis. That is called the penile attack is erectile dysfunction, whereas the heart attack is the heart attack. So when the patient has got attack on the penis, eventually he is going to have the attack on the heart also. So erectile dysfunction, the patient complains of, you cannot ignore. It is not only to have the sexual satisfaction, even to prevent the forthcoming cardiovascular disease and death, you need to be very cautious as far as this microalbuminuria is concerned and the erectile dysfunction is concerned. These are the sensitive indicators actually, because the penis is running short of blood. That is the reason why we use the phosphodiesterase 5 inhibitors, 5-PDE, like sildenafil citrate and the tadalafil citrate and the avalafil. So many are there, but we have got only 2 molecules in our country. We have got only sildenafil citrate and tadalafil. That's it. We have got only 2 molecules to treat that. But all the time, whenever you come across with erectile dysfunction or the premature ejaculation put together or the ED plus PE, always keep it in mind that the patient is going to have attack on the heart. And never be under impression that only males have erectile dysfunction, females also have the same quantity of erectile dysfunction. The definition is one and same actually. So the females are at risk of developing heart attack with the erectile dysfunction, and the males with erectile dysfunction and the microalbuminuria are at the risk of developing this particular the heart attacks. So to prevent that, you have to be very cautious. The pre-diabetes, there are some insulin resistant conditions. That is diabetes, pre-diabetes, heart failure is an insulin resistant condition, and erectile dysfunction is an insulin resistant condition. So all these conditions, they predispose to the future cardiovascular diseases, and the morbidity goes up and the mortality goes up. You want to bring down the death rate, you need to meticulously control the pre-diabetes, and you can always motivate the patient that pre-diabetes is a reversible condition. You can always reverse that, certainly. Like the first stage of the chronic kidney disease, that is microalbuminuria, is always reversible. If you cannot find out the patient, if you cannot screen out the patient, if you cannot pick the patient at the stage of the microalbuminuria, and once the patient goes on to the macroalbuminuria, there are less chances for reversal. There are still chances for reversal even in macroalbuminuria, but when compared to microalbuminuria, the chances are less. So try to pick up the patients at the stage of microalbuminuria by screening, and try to pick up the patients at the stage of pre-diabetes, to pick up the patient, not allowing him to getting on to over diabetes and die miserably with the cardiovascular disease or the chronic kidney disease, where the incidence is at par with the type 2 diabetes per se. I think Dr. Humayun, is it okay for you? And the per se, the answer is no. Pre-diabetes, there is no role for any drug other than the metformin, and even that is pharmacological therapy is mandatory for the pre-diabetes, management of pre-diabetes. For reversal, it is very important that one should be put on metformin 500 milligram to 2 grams, and prior to that, much important is the non-pharmacological therapy, that is the lifestyle modification and therapeutic lifestyle changes, which are even more important than metformin. Once you put the patient on metformin, he thinks that okay, the pill is going to do everything for me, so I don't need to diet, I don't need to exercise. So emphasize, you counsel the patient in the stage of pre-diabetes, the importance of diet, exercise, reduction in the weight, and the reversal of the pre-diabetes. They go to you take the normal pathophysiology of the natural history of the type 2 diabetes. See, first it is normoglycemia, followed by impaired fasting glucose, followed by impaired glucose tolerance, and put together pre-diabetes, then over type 2 diabetes. So you want to cut that chain, you want to get back to normalcy. So pre-diabetes is the stage where you can 100% get the patient back to normalcy. That is, euglycemic state can be achieved by meticulous counseling, the non-pharmacological methods, the lifestyle modification and the therapeutic lifestyle changes, along with metformin. There is no drug at all to be used in case of pre-diabetes. No DPP4 inhibitor, no SGLT2 inhibitor, no insulin, and no GLP-1 receptor, no alpha glucosidase inhibitor, no thiazolidine, nothing. See, multiple drugs are used in the DPPs, that is the diabetes prevention studies are there. They're done with metformin, done with acarbose, done with this rosiglitazone, but the final inference is that the natural lifestyle method is much more cost effective than these drugs. So finally, the conclusion, what I conclude by saying is the non-pharmacological therapy plus metformin is the therapy for pre-diabetes. No other drugs, please. So you can try all these drugs in type 2 diabetes except one combination, that is insulin with the pioglitazone. And one more thing, you have to be very cautious in patients who are on this particular the SGLT2 inhibitors. When the patient, the doctor says you have to be on insulin, the clinicians have to be very cautious with regards to hypoglycemia in two conditions: where the patient is on SGLT2 inhibitor and where the patient is on sulfonylurea, and where the doctor wants to put the patient on insulin. You need to reduce the dose of sulfonylurea, you need to reduce the dose of insulin in the presence of SGLT2 inhibitors because of the fear of hypoglycemia. Hypoglycemia is not just because of SGLT2 inhibitor, because of the reductions are more. When you keep the high dose of insulin, eventually the patient lands up in this particular hypoglycemia. And if you don't reduce the dose of sulfonylurea, the best thing I would advise is take off sulfonylurea when you want to put the patient on insulin when the patient is on SGLT2 inhibitor. So you can keep now the best combination on the earth is the combination with metformin, the DPP4 inhibitor, and the SGLT2 inhibitor, which are very widely available in India. All triple drug combinations are there with metformin, DPP4, and SGLT2 inhibitors. That is the best way of starting the treatment in a newly detected type 2 diabetes patient to have the benefits. They can enjoy the benefits of this, the cardiovascular, the renal, or the hepatic benefits only if these drugs, the SGLT2s, are started in the initial course of the disease. You start after 20 years, it is virtually useless. That's going to reduce the blood sugars as an add-on therapy. That's going to reduce the A1C, but not the cardiovascular benefits, not the renal benefits, not the hepatic benefits. So you want to enjoy you want to allow your patient to enjoy all the benefits of SGLT2 inhibitors. Put the patient in the initial period of the disease. The moment the patient walks in, there is no contraindication. You straight away go to this particular class of drugs. And the one more thing I would like to mention is there is only one contraindication for this DPP4 inhibitors theoretically. Once the patient has got past history of pancreatitis, please avoid DPP4 inhibitors, as DPP4 inhibitors have got a tendency to flare up the acute pancreatitis. So you just ask the patient only the one or two questions, whether the patient had got this particular the pain abdomen radiating to back are associated with vomitings. Again, this particular the pancreatitis, acute pancreatitis, is divided into three categories. The one is the clinical acute pancreatitis, that is the pain in the stomach which radiates to back because pancreas being a retroperitoneal organ. And second thing is it is always associated with vomitings. This is called the clinical diagnosis of the acute pancreatitis. And the biochemical conclusion is done with amylase and lipase. And the off late the research says though you don't do amylase also, there is no difference, but lipase is mandatory. If you are going to do only one, you do lipase. You can skip amylase. Amylase has got no significance as far as acute pancreatitis is concerned. You can go for simple serum lipase, which is grossly elevated. And third one is this particular imaging radiology, that is starting from an ultrasonogram to CT to MRI, all the modalities. You can diagnose this particular swollen the edematous pancreas with the patients with pain abdomen, vomiting on one hand, with increased lipase amylase on the other hand. Lipase is very, very important. It cannot be ignored. You can ignore amylase but not lipase, please. So I think it's clear. Are there any questions, Naresh?
Yes, sir. One more question is there.
Yeah, very. I cannot see that.
Sir, that Anand.
Yeah, my good friend Dr. Anandu Chandran. So very nice to see Dr. Humayun Hussain from Saudi Arabia and Anandu Chandran from Kerala. Sir, you have mentioned initiating SGLT2 inhibitors or DP4 inhibitors as a primary drug in type 2 diabetes instead of metformin. Can you explain, please? Yeah, it's a good question, but Anandu, I always say that as per the European Society of Cardiology, wherein dating back to 2019, it clearly mentioned it was the first international body to endorse this particular usage of either SGLT2 inhibitors or the GLP-1 receptors in newly diagnosed type 2 diabetes patients to start even without going for metformin. Only in two conditions it said: the patient at risk of developing atherosclerotic cardiovascular disease or the heart failure or the hospitalization for heart failure, or the patient with established atherosclerotic cardiovascular disease and the heart failure. These are the two conditions it clearly mentioned, wherein you need not go to metformin, you can straight away go to the SGLT2 inhibitors, where the atheromatous, the atherosclerotic, the cardiovascular disease, that is the 3-point MACE or the 4-point MACE or the 5-point MACE is concerned, you go for GLP-1 receptor agonist, where atherosclerosis is the predominant pathological defect, and where the heart failure predominates or the hospitalization for heart failure predominates, go to SGLT2 inhibitors, and if possible combine both to have the synergistic effect. I never said that ignore metformin and only use this as monotherapy. This is the only one condition wherein that is established atherosclerotic cardiovascular disease and heart failure, or at risk of developing atherosclerotic cardiovascular disease. By calculating the Framingham heart score and all, you can assess the cardiovascular risk in the coming 10 years. So by calculating that and all, you can come to a conclusion whether the patient is at risk of developing or already the patient has got. Then followed by the EASD joined hands with this particular ESC recommendations, and I said after that the patient irrespective of baseline A1C, that's what I said. So when the patient is not to the target, you always can add metformin, you always can add DPP4 inhibitor, the other drugs with proven cardiovascular safety, that is the COVTs must be very positive. Then select that particular the drugs, and I said do not use the pioglitazone for the fear of precipitation of heart failure, and the saxagliptin, the only DPP4 inhibitor that induces heart failure actually. So these are the conditions I said. So I think the answer is clear to you, Anandu. So in general, the dictum is that the treatment of type 2 diabetes mellitus starts with a non-pharmacological therapy plus metformin. Unless otherwise metformin is contraindicated or not tolerated by the patients, you cannot ignore metformin. But only condition is the patient has got established atherosclerotic cardiovascular disease or heart failure. Without metformin, you can straight away use as monotherapy the SGLT2, and you can add GLP-1 receptor to that. It has got a wonderful synergistic effect. You must be remembering the additive effect and the synergistic effect. The 1 plus 1 becomes 1 in additive effect, 1 plus 1 becomes 4 in synergistic effect. That is basic pharmacology, Anandu. I think you are clear, Anandu, and Dr. Humayun Hussain and Dr. Anandu. Any more questions, please? You can enlighten the audience with your wonderful questions. Naresh, any more questions, please?
No, sir, there is no question.
No question. So one
Yes, sir.
more thing. Yeah, Humayun Hussain. Yeah, yes, sir. Thank you so much for so elaborative explanation of the topic. As always, you talk and lecture on any topic. Is extremely informative, excellent, and elaborative. Thanks a lot, sir. You are most welcome, my friend, Dr. Humayun Hussain. And you explained the full topic in so detail. Your talk is always unique. It's extremely beneficial for all of us. Thanks a lot, sir. Thank you so much, Dr. Humayun Hussain, for your kind compliments and kind words of concern and appreciation and encouragement. And as usual, Anandu Chandran said it is clear. Very good. So, I think if there are no questions, we can wind up the session and see you again on, I think, tomorrow. Tomorrow, both of us, ma'am and mm, we both are giving a talk on insulins, a very interesting topic again, and again insulin co-formulations, the insulin degludec and aspart. We both will be delivering lectures by 5 o'clock, I think tomorrow tentatively. So because the iftar is there, the fasting people can have their food in time. So we start early tomorrow, 5 o'clock Indian Standard Time, Dr. Humayun Hussain and Anandu. So 5 to 6:30 or 7 it goes on. Both of us will talk on insulins. Again, I think 20 this month I have got a regular curriculum, I think, on daily basis. So I'll let you know the schedule to both of you especially, because you are so keen and so interested to listen to me. Thank you so much for patient listening, Dr. Humayun Hussain and Dr. Anand Chandran especially, and to all the professional colleagues who have joined this session for your patient listening. I think you can wind up, Naresh.
Yes, sir.